So I may have lost that first recording. So we'll see.
Yeah. Is that okay? That's the only thing. Number 2.
Must be 2 hours. 2 hours, right?
What?
2 hours.
Yes.
Oh, for the love of everything good and wonderful. Oh, crap. All right. I'm having technical difficulties. So, I don't know what's going on. Anyways, I know I need to hurry up now.
You enjoy talking about this kind of thing.
I know, good love
You should
labor.
teach yourself that you hate.
I love labor. All right, so let's get back on topic here. Let me make sure. Oh my goodness. Anyways, if I have to record this again, I'm going to shoot myself in the brain. Just want everybody to know it. That's what's going to happen. Okay. What? Okay, here we go. So we've done over 4th stage recovery, and we're trying to decide whether or not we can send her to OB. And all these things need to happen. She needs to have stable vital signs, her bleeding needs to be stable, her bladder needs to be empty, her fundus needs to be firm, and she needs to be able to walk. Does that always happen? No. Especially the walking part. So you had a gal who had an epidural, you don't turn it off until they're done doing the episiotomy repair. Okay? And then you turn it off, and then you're hoping that within 2 to 3 hours she can get up and walk to the bathroom, and sometimes that happens, but occasionally it doesn't. So we need assistance with transfers and things like that for this gal. Okay. So I guess we're going to go back to the 1st stage of labor now. Now, when we have a gal who comes in and she doesn't want an epidural, that's great. I love it, but it's more work for me actually, because I'm pretty much at the bedside the whole time throughout her labor, which is not a terrible thing. I got to be somewhere the whole 12 hours I'm there, but anyways. If they don't have an epidural, we like women to get up and walk around. We like them to sit on the birthing ball. When they sit on the birthing ball, that birthing ball just helps open that pelvis and get baby to come down through. We like them to get in the jacuzzi tubs. It helps relax them because when you don't have epidural on board and you're really tense with contractions, okay, a couple of things are going to happen. One, if you're doing this through contractions, you're decreasing oxygen to the uterus. Okay, one, that decreases oxygen to the baby, of course, but it also inhibits the effectiveness of the dilation. Okay, the other thing is like when that woman's really tense, it's almost like she's literally placing a wall between her cervix and the uterus, where the uterus is banging these contractions down on this wall and not on this cervix. Okay, so if she's really tense through contractions, that's going to inhibit her progress. I mean, it's not going to stop it. She's still going to deliver, but it might take a little longer because she's not relaxing through these. And then, stress causes that cortisol release, okay, and stress hormone, so that affects things negatively as well. So a lot of things that we can do is change positions. I mean, like if you're having contractions and you're sitting in the bed in the same position, you're basically just laying there letting someone hit you in the head with a bat. Okay? So move her around. Okay? And especially if she has an epidural. Do we need to move moms anymore if they have an epidural and they're pain-free? We need to move moms because if mom is stationary, chances are your baby is stationary. Okay, and if you move mom, that helps facilitate baby's descent. Okay.
How do you move her if she's got an epidural?
So you side to side. We use a thing called a peanut ball for those of you who didn't get a tour. It is basically a big ball about this big, about this long, and kind of like this big around, the shape of a peanut. And we put that between mom's legs to help keep the pelvis open. Okay, so that baby can come down. Water therapy, I already told about the jacuzzi tub. Yes?
Can they use the jacuzzi if their water's broken?
Uh-huh. Yep. So moms in labor, they heat up. They're hot and sweaty. I usually take one of those pink basins, or they're gray, but just those little basins. I fill it with ice water. I put rags in there. So the support people can always have cool cloths on her, okay? Especially if she's sitting in the jacuzzi, hot water, small room, hot, okay? Especially if her water's broke, keep her pads underneath of her changed so she's not sitting in a puddle for 12 hours, okay? Some of this, I'm gonna kind of, you guys know, I like to just, there you go, no, sorry, let me go back. So second stage, a lot of times we are really helping mom with pushing, we're counting, we're keeping her refocused. Sometimes she'll stop pushing because it hurts really bad, and she won't want to push, and we've got to encourage her. Sometimes it's like, you're doing great, just keep pushing, this is normal, and other times is, push now! I've gotten mouthy with people. Not mouthy, but I mean some really, it's extremely painful. They feel like their bottom is going to split right in half, and they stop pushing, and we've got to somehow convince them to start pushing again. Okay, all right. So the first thing we do for baby is we put baby up on the chest and we dry the baby. That's a dual purpose. Drying the baby stimulates the baby, makes the baby want to cry, which is a good thing. We want babies to cry, so they open those alveoli sacs and they push that fluid into the tissues to get absorbed. Okay, and then we want to dry them so that they get warm. Okay, we don't want this evaporative heat loss because we have a wet baby, and then the baby gets cold, and then the baby's blood sugar drops, and then the baby starts having respiratory and cardiac issues, and then it's really bad. So we want to keep this baby dry and warm. Okay, we assess their respirations, their heart rate, their color, and their tone. Okay, those are the big things. So when we assess the tone, we pick up an arm and we drop it and see if baby controls that. But if we pick up that arm and it goes like that, then we don't have an oxygenated baby. Okay, so we're watching baby's tone, we're watching their color. When babies are born, they are born blue. Their oxygen saturation in utero is probably 68. That's normal. So when they come out, they look a little blue. All right, but we want them to pink up as they start crying and breathing. Okay, so we watch that they're pinking up. And their whole body may be pink, but their lips and mucous membranes are blue. Is that okay? No. That's called central cyanosis. That is oxygen deprivation. If their hands and feet are blue, is that okay? Yes. Yeah. That's acrocyanosis. That's normal. That's all the blood is going to the vital organs right now to kick things into gear. Okay? Hands and feet don't really need a lot of blood right now. Okay? So we're watching those things. We're keeping our baby warm and dry. We do our APGAR scoring. So we'll look at APGAR score here in a second. We do a head-to-toe assessment, but it's not immediate. So I don't care about the head-to-toe assessment. I'm caring about these things right here, the respirations, oxygenation, heart rate, okay? And then after mom and dad love baby and breastfeed baby and do all these great things with baby for an hour or two, then I'll take baby to the warmer and I'll do a complete head to toe assessment on my baby, but not right away. But right away we'll get the identification bands on and the security band on. Okay, baby, we have these bands that have, there's 4 bands. They have black numbers printed on them. All 4 bands are identical. The information we write on all 4 bands is identical. Baby gets 2, mom gets 1, support person gets the other. Okay, that's how we keep babies to the right people. Okay, and then they get an alarm band like a baby low jack. It's connected to the alarm system, and so if baby tries to take off, then the alarms go off. Okay, and then we try to get breastfeeding right away. Everything can wait if breastfeeding is occurring, okay? Jeez, wait. All right.
I have a question on breastfeeding.
Yeah.
When we were at St. Pat's last time with the lactation specialist, she showed us that video.
Mm-hmm.
And it could take up to an hour for the baby to crawl up there and do it himself.
Uh-huh.
Do you guys let that occur?
No, we don't. We're too busy to let that occur, but that is evidence-based practice to do the breast crawl, the breastfeeding crawl. And if you leave a baby on a mom's chest, the baby will crawl to the breast and will latch on. I don't have time for that. No one has time for that. Ain't nobody got time for that. Anyways, so we get it going. We got to get it going. All right, so here's the APGAR scoring. So we score babies at 1 minute and 5 minutes on heart rate, respirations, muscle tone, reflex response, and skin color. Okay, at 1 and 5 minutes. The highest score on this is a 10, and most pediatricians say if you live in high altitudes, you cannot achieve a 10, or babies cannot achieve a 10. But I've had a hard time on some babies not giving them a 10. Anyways, between 8 and 10, you really have a good baby. Anything 7 or below, you might have a questionable baby that you have to watch more frequently. But if you get any score below a 7, you have to continue doing APGAR scores every 5 minutes up to 20 minutes. But if you have a baby that's scoring below 7 on their APGAR scores, they're probably getting some sort of intervention already. And who cares about the APGAR score? We got things to do, like help this baby breathe, okay? But technically, they're supposed to be done every 5 minutes up until 20, or until you get APGAR scores greater than 7, okay? 7 or greater. But the APGAR scoring has nothing to do with whether or not you should resuscitate your baby. You don't wait for the APGAR score to decide whether or not you should intervene, okay? You may be intervening at 30 seconds of life, and the first APGAR score isn't due until 1 minute, okay? All right, so normal respirations for babies, this says 36 to 60. 40 to 60 is a little easier number. However, if I get a baby whose respiratory rate is 32, they're oxygenating, or their saturations are good, they're pink, centrally pink, they have good tone, I'm going to accept 32, okay? But normal is like 40 to 60. Apical heart rate, normal is 110 to 160, okay? I've had babies who have had apical heart rates at 90. They were centrally pink. They were breathing normally. They had good muscle tone. I called the physician and we did nothing. Okay? All right, so you look at all your other parameters. Skin temperature. We don't do skin temps on baby. We do axillary temps. And we want baby's temperature to be 97.6 to 96.6. Anything out of those parameters, we're going to be probably intervening for baby. Now, we get babies who have elevated temps because they've been skin to skin with mom, they have a warm blanket on, she's covered up, and everybody's starting to get hot. Is basically all it is. But when we're concerned about baby's temperatures, we're more concerned about low temperatures because baby does not have the metabolism, the strength, or the reserves to generate heat like we do when we're having a problem. okay? So if we see low temps on babies, we start jumping through hoops. We're watching skin color. We do assess so when the baby's born, we look at the umbilical cord and we're verifying if we have 2 arteries in one vein. And that's probably the last time you're going to be able to tell that, because that cord is going to start drying up. And it's going to be very difficult to assess. But once you assess and someone says, yes, we have 2 arteries in one vein, we're always going to have 2 arteries in one vein. So it doesn't need to be documented all day long, okay? Gestational age, we want to document the gestational age because our care may be different if we have a preterm and postterm baby, okay? I hate that they threw soles of feet in here, creases on the soles. Creases on the soles are is one screening that you can do to assess whether you got a term baby or not. Okay, if they have a lot of creases on the soles of their feet, they're more termish. If they have a smooth foot, they're more pretermish. Okay. All right. Questions?
What would it mean if you had?
So usually if you have 1 artery in one vein, then you probably have a small gestational baby or maybe even a preterm baby. After delivery, who cares, because you got what you got, and those 1 arteries in one veins are not doing anything for the baby. Okay, but in utero, that may have presented a growth, nutrition, oxygenation issue for baby. So then you may be dealing with a baby who is compromised now. Okay, but if you got one vein, 1 artery, and you've got a perfect baby, then we're okay. All right, so let's run through pharmacologic men of labor. Okay, so we used to wait till the woman was in a good labor pattern and advancedly dilated, 4 to 6 centimeters, before we'd let her have pain medicine. 4 centimeters if she was a multip, just because multips usually go faster. So if they start at 4, then they're probably going to go faster and be in a good labor pattern. But a primip, we usually like to wait till about 6 before we really say that they're in a good labor pattern, so that if we give pain medicine, we're not slowing down their labor. We definitely want mom to consent to pain medicine. We don't want to give pain medicine if mom doesn't want it, right? Anyways, we want the mom's vital signs to be stable before we give pain medicine. So if she has elevated blood pressures, we're not going to withhold pain medicine. If we're not fixing the blood pressures, we're going to watch and treat our blood pressures and still give her pain medicine. One of the reasons why, your blood pressure can be elevated as a pain response. So, but if we had a mom who had a respiratory rate of 8 to 10, which is abnormal, right? Or if they were hypotensive to the point that they were symptomatic, we would take care of that issue before we would give pain medicine, because pain medicine is just going to enhance those problems. Okay? Yes?
On the quiz, there was a question about a mom who was hypotensive and what do you do? And I chose make sure that there's no cord compression or like left leaning or whatever it was to get them off the vena cava. And that was wrong. Does that not affect blood pressure? Is that
okay? So the uterus being on the vena cava can affect blood pressure, because then it's decreasing the blood to the heart, which decreases cardiac output. Okay, but the issue with the uterus being on the vena cava is a baby issue more so than anything else. Okay, so if we get, if we have that pressure on the vena cava, then the uterus is going to get undersupplied. Okay, but that question was put in there because we have a mom who's hypotensive and symptomatic. So, do we treat the baby or do we treat the mom? We treat the mom, we treat the person, because if we can't get her blood pressure up, no matter what we do to the baby, it's not going to help. Mom has to have a blood pressure, okay? So simultaneously helps the baby. Okay? All right, so let's go. Okay, so also with giving pain medicine, we need to make sure that our baby's heart rates are okay. Because if we give pain medicine that crosses the placenta, it's going to affect the baby. And if we have a baby who's already being affected by something, we're probably going to compound that. Okay, so we don't really want to be doing all that kind of stuff if we have compromised babies. Now, this is pain medicine that's systemic. That means it goes through mom's venous circulation and it crosses the placenta. Epidurals, spinal anesthesia, does not cross the placenta. Okay, so if your woman wants an epidural and she's having trouble with her baby's heart rates, we're going to go ahead and give the epidural. The only, and we'll get into this, and I want to repeat it because it's probably going to be a test question. The only problem with an epidural as it relates to a baby is not that the epidural medicine crosses the placenta and infects the baby. It's because the epidural has systemically relaxed blood pressure. Okay, it vasodilates and it mom's blood pressure typically drops with a spinal anesthesia or an epidural. Okay, if mom's blood pressure drops, what's going to happen to baby? Heart rates are going to drop. Okay, so that's how the epidural affects the baby. It's as a consequence of mom's hypotension as a side effect from the epidural. Okay, so we need to bump up mom's blood pressure in order to improve our baby. Okay, so that's a fluid bolus, position change, whatever. Okay. All right. Oh, and this also said a term fetus. We don't give pain medicine to women who are in labor who are not term. No. Okay? We give pain medicine to 36-weekers who are in labor. We give pain medicine to 24-weekers who are in labor. We give pain medicine to women who are in labor. Okay? I will make sure that there is not a test question like this because this is actually wrong. Okay? Textbook-wise, we don't live in a textbook society. No one reads the textbook before they present, and neither do babies. So there will not be a test question like that on my test. Okay?
So in NCLEX world, you don't give pain meds preterm in real life.
If that is your only option of a correct answer, that would be a correct answer. Okay? But if it said something like, a preterm fetus with a category 1 strip. Is category 1 strip good? Yeah. Yeah, category 1 is good. So if it tricked you that way, then put all your things together and say, well, I got a category 1, I got a preterm fetus, okay, I'm going to go ahead and give meds. Okay? All right. So, in labor we assess their contraction pattern, of course, and cervical changes. So we're assessing all these things when we check her cervix. We're checking the position of what? The baby. We're checking the position of the baby. The consistency of the cervix, the effacement, the dilation, the station. So how far is baby up or down? Okay. Now, one of the things, as far as, I guess this could be baby / cervix, because you'll hear someone say her cervix is very posterior. It's in a posterior position. That means it's way back in her vagina. Okay? Or they'll say her cervix is anterior. That means it's way front. Okay? Which is good. Posterior is fine too. It'll change. That cervix will come around. Or she won't have a vaginal delivery. But anyways, so that's what we're doing. Okay. Oh, and back to that slide, when I said we don't give pain medicine to people unless they're 4 to 6 centimeters. Well, that's the way we used to do things, but now that we run Pitocin on everybody, we don't care. Because I'm not going to slow down her labor if I'm running Pitocin, because I'm going to keep her labor going with the Pitocin. So if she's 2 centimeters and she wants fentanyl, she's going to get it. Okay? All right. All All right, so basically with any other medication, you're going to make sure you know her allergies. You're going to give them the information about the medicine, especially because we give fentanyl. That's the narcotic we give in labor 99% of the time, and it makes them feel drugged. And a lot of times women feel like they're not breathing. Like they're so relaxed, they don't feel like they're breathing. And so it sometimes it makes them very anxious. But we need to let them know that's a normal feeling. However, you are breathing, because since I've given fentanyl, you're on a continuous oxygen saturation monitor and you're saturating at 100%. So just try to relax, close your eyes, go with it, ride the wave. Anyways, so we gotta assess everything: vital signs, the baby, the contraction pattern, the pain level, when we give them, before we give the medicine, and after. And so we're going to be continually assessing these. Okay. Of course, you know, the effectiveness. We're assessing her pain level after we give the medication, because if it works, great. If it doesn't work, we need to try something different. And I'll tell you, with fentanyl and with most narcotics we give in labor, it's either the combination that with each subsequent dose they don't work as well, and with each subsequent dose the contractions are also getting stronger, so the medication isn't working very well. So she might have a couple of doses of fentanyl during labor, and then she'll say, like, this isn't helping at all, and then now we're going to go with the epidural. Okay, so so we give opioids is what we give. Okay, we sometimes give them with antiemetics or sedatives. Mainly, the antiemetics, like some narcotics, make you nauseated, so we give the antiemetic with it. But with the antiemetic and the sedatives, they potentiate the effects of the narcotic, so they make them a little more better. All right, but we don't want, we don't want lethargic, unresponsive, sedated women in labor, because then these are going peripherally, these are going systemic, so they're crossing the placenta, so what we're doing to mom, we're also doing to baby. These are the 4 different drugs that are typically used in labor. And Demerol is pretty much, current practice is pretty much has gone completely out of favor. We might occasionally give Demerol to a woman who comes in and either early or prodromal, long, early, not dilating, early labor, or extremely painful Braxton Hicks. We might give her Demerol and send her home. Sometimes, but not a lot anymore. But in labor, we rarely ever use, well, we never use Demerol. We always use fentanyl. Different places in the countries do different things. Back east, I did a lot of Stadol and Nubane for labor pain, but here, not so much. So these next slides, I'm not going to go through them. I'm just going to pass them really quick. But the next slides take each one of those drugs. They show you the route, the dose, the peak of action. And pretty much all of these we repeat every hour as long as mom wants it. Okay? Except the Demerol. I think it's every 4 hours. Nubane. So Demerol, fentanyl, this is our drug of choice. And then here's a nice little table. You can see them all together, so you can study these, okay? Now here's our analgesic potentiators. Basically these are sedatives or antiemetics that we're giving along with our narcotic, okay? Now Narcan is a drug that you can give to reverse the effects of your narcotic, okay? So if you've given too much fentanyl and your woman's respiratory rate is now 8, okay, shoot her with Narcan. That fast, she'll pop out of it, okay? Except if you have a person who is an active drug abuser and you give them Narcan, you'll put them in seizures, okay? And we don't give these, we used to always give these to babies as well. So if we had a mom who we gave fentanyl to and she delivered within the hour, then baby's going to come out sedated from the effects of the fentanyl and not want to breathe. So we used to give babies Narcan, and that's going out of favor. Now we're just doing our stimulation, and we'll provide supplemental oxygen if we need to.
Can we give baby seizures if mom's been using?
Mm-hmm. Yeah, because if mom's using, so is baby.
So what do you do then if the mom has a history of drug abuse?
We would not give
Or
Narcan.
she's
Or
lying
you
about
don't give fentanyl?
Well, we would go ahead and give it, but you know, we would have to be careful not to, you know, make sure we're monitoring her and not giving her too much. But I've hit women with so much medication, I thought I'd drop a horse, and she's wanting more. So, okay, all right. So regional anesthesia are your spinals, your epidurals, okay, and intrathecals. Temporary loss of some sensation or a complete numbness from the belly down, okay. Advantages of an epidural is, yeah, she's fully awake, but she's either not feeling her contractions at all, or she feels them, but they are not painful at all. She can feel the tightening or pressure, but not the pain. The big problem is hypotension, okay? So within the first 30 minutes is usually when this happens. Mom has a systemic reaction to, not a reaction, but because of the muscle relaxation effects of the epidural, it causes relaxation of the vasculature, and so it drops her blood pressure. And then that's a problem for both mom and baby, so we need to treat that. We prepare for that because we just assume everybody's going to have a hypotensive issue after an epidural, so we give them a 500 to 1,000 cc bolus before it's ever put in. Like the 15 minutes before it's put in, we dump a bag of fluid in, okay? And hopefully that's enough to support.
No parents are.
Oh, okay. That's enough to support her from having hypotension. Prolonged labor, so that's why we didn't let women have medication, even epidurals, before 4 to 6 centimeters. But we don't care anymore because we run Pitocin. Okay? All right. Yeah, don't give it if the patient refuses, right? Okay. The other big thing with epidurals is if mom has a coagulopathy problem, anesthesia will not place an epidural. Okay? So we watch women's platelets. So we do a CBC on admission, and if her platelets, depending on your anesthesia, if her platelets are below 100, they will not give her an epidural. But then some anesthesias, if it's between 50 and 70, they'll stretch it to 50 or 70. If her platelets are 50 to 70, they will not give an epidural. All right. Anyways, so yeah, we want the woman to void before we place this, but I'm fine if she doesn't, because I'm going to have to put a Foley in, and it's nice to see that urine return. But anyways, so when she has her epidural, we're monitoring her blood pressure, pulse, respirations, and fetal heart rates for the first 30 minutes. We do it every 2 minutes times 5. You don't have to write this down. Then we do it every 5 minutes times 4, and then every 15 minutes till stable, then every 30 minutes or something like that. So we watch her blood pressures pretty frequently right after the epidural. She is on continuous monitoring if she gets an epidural. So positioning for the placement of the epidural, most anesthesiologists want them sitting on the bedside or dangling, and then should we put a pillow in front of her chest to hold? And I can't do this because my back's hurting, but we tuck her chin and we make her round down around her baby and push this low part of her back out like a mad cat. Okay, that helps open up the spaces between the vertebrae so that the anesthesia can just slide right in. But some anesthesias will do the women on their side in kind of like a fetal position. Basically the same thing, but only laying down. Okay, and then we do our fluid bolus. We do our frequent assessments. Assess sensory motor ability every 30 minutes. So can you move your legs? Well, not so much. Okay, fine. Then I'm going to take an alcohol wipe, a cold alcohol wipe, and I'm going to brush her neck with it. And I'm going to say, does that feel cold? She's going to say yes. And then I'm going to keep going down her body, and I'm going to say, tell me when it doesn't feel the same. Okay? So she says it doesn't feel the same right there. So that's about T7, T8 in the dermatomes. Okay? So I chart that. That's part of our assessment. Okay? And then assess for bladder distension. We're going to put in an indwelling. Okay? And then positioning of these women, we want to make sure that we have them in a good anatomical position. Okay, so if you just let her all be all something cockeyed, then when the anesthesia wears off, she's going to feel that. Okay, so let's keep her in proper alignment. So one of the other big side effects from an epidural or a spinal is itching, pruritus. Okay, hand them a bottle of lotion because that's just what happens when you get an epidural. That's the kind of the switch, all right? They're going to itch, all right? Okay, so they could put opioids in the anesthesia. These are all anesthesia type responsibilities. Pretty much everything is about the same. It doesn't matter what kind of epidural she gets. The side effects, the contraindications, and the care are all pretty much the same, okay? So I'm just going to kind of breeze through here. So spinal anesthesia, they go into a different place in her spine. They go right into the spinal space for spinal anesthesia. They put the needle in. It's given the same way. We still do the fluid bolus. We put the needle in. He injects the medicine, and then he pulls the needle out. We usually use these for C-sections because they have a more complete numbing. Like she feels nothing. Okay? With the epidural, she might feel that she's having a contraction. Okay? She might be able to move a little bit. With the spinal, they're done. They're toast. Everything's dead from here down with the spinal. And we use that for C-sections. Okay? A lot of things are the same as far as, hypotension is the big thing, okay? Greater potential for fetal hypoxia. If mom has hypotension with an epidural or a spinal, you're going to have fetal hypoxia. You're going to drop your fetal heart rate, period. End of story, okay? You do the same things for recovery, okay? There's your contraindications. Patient refused and coagulation problems. They won't get spinal. So this is just, so we're doing a fluid bolus. We always put 18 gauges in pregnant women. Always. Okay? That's a standard in our unit. So IV catheters. 18 gauge IV catheters. Positioning is the same. We don't usually do spinal block for a vaginal delivery. We don't do spinal blocks for vaginal deliveries. We do epidurals. Okay, but you could give her a spinal block. Good luck pushing that baby out. She feels nothing. She feels absolutely nothing. Okay. Recovery is a lot longer. So when a woman has an epidural, and I may have missed saying this, but an epidural, for those of you who don't know, it's in the epidural space in the spine. They stick the needle in, they thread a catheter through, very tiny catheter, flexible, soft, and they pull the needle out and the catheter stays in there. And then it's taped to her back and it's connected to a continuous infusion of medication. Okay? The spinal, like I said, is a needle in, inject the medicine, pull the needle out. Nothing is in her back. Longer recovery. She may be numb and not able to move her legs for up to 6 to 12 hours. Okay, she does have a Foley in because women who have spinals are having C-sections and they get a Foley. Okay, and that Foley usually is in for 24 hours, and especially until they're up walking around. Okay, which could be 6 to 12 hours. So So the combined spinal epidural really is, we had a woman in labor. She has had an epidural throughout the labor, and then we're just going to advance it a little bit and get into the spinal space and dose her with a spinal and then take her to C-section. Okay? Or they actually do go into the spinal space. They inject medicine into the spinal space, and then they pull the catheter back a little bit into the epidural space and leave it there. Okay? So that's the combined. We don't do that either. Excuse me, my belly is growling for breakfast. A pudendal block is, so this is, there's a, oh, there it is. A pudendal block. So we're actually sticking it, this is a woman who's doing a vaginal delivery, and you know when I said it feels like she's tearing in half and she stops pushing? So if we have a woman where we can't get her to push no matter what because of the pain, we can numb this pudendal nerve. Okay, so it's just going to numb this area, and it's a needle that they have lidocaine in the syringe, and they go in vaginally. This needle has a cover on it so that he doesn't jab her somewhere he's not supposed to. And he goes in, and then he slides back the cover, and he finds this nerve, and he injects this nerve with lidocaine. It's called a pudendal block. And we don't do them very often, but anyways, that's just for the gal who's pushing, okay? Or the episiotomy repair. So, yes?
You do both sides?
They usually do, yeah. So episiotomy repair, usually we just do lidocaine locally, okay? But if we did lidocaine locally to repair and she's still coming out of the bed, then we'll do the pudendal block, okay? And the physician does this. We nurses don't do this, okay? So anyways, there's your disadvantages. There's another horrific view, okay? This one just kind of shows you, can you see that very well? I can't see without my glasses on. So the pudendal block, you can see, so this nerve right here that they're getting, it only innervates that lower area, okay? So if they get an epidural, they're getting the nerves that innervate that whole upper spinal, epidural, those areas, okay? So that's just a look-see. All right, so I'm not going to go through these reactions. You guys can look at those. Nausea and vomiting and hypotension and headache, they're standard side effects to anything, right? Okay. I want to get to so, you know, we've bolused this gal before the epidural placement to try to prevent hypotension, but what happens if we still then get hypotension? Well, it's another bolus. It's oxygenation, oxygen. We may have to put her head flat. A lot of women will do fine in the flat position, and then you start raising their head up, and then they start tanking, okay? So putting their head flat, and then ephedrine is our drug of choice to treat profound hypotension, okay? We will give 5 milligrams. Usually it's 5 milligrams IV push, and it can be repeated like every 5 minutes until you've recovered your blood pressure. So, okay, we all know that our gal's not going to be able to move very well. She has an epidural, so help with ambulation. Alterations in fetal heart rate are a direct response to the hypotension. So if we fix the hypotension, we fix the baby, hopefully. Okay? All right, general anesthesia. I wanted to get to this. We only do general anesthesia in the rare emergent situation, okay? So we have a gal in labor, and we had that cord prolapse that we talked about. That's an obstetrical emergency. If she, we would run her to OR and put the mask on, put her out, cut the baby out fast. Okay. So in a situation like that, we would do general anesthesia. It's an emergency situation. We only use it in an emergency situation. Now, if we had a gal, we've had gals that have had some sort of trauma to their spine, and anesthesia could not get the spinal in, or she's extremely fluffy, and he could not get the spinal in, could not. And we've used general anesthesia on those women, okay? But it's not preferred, all right? It's not, whoa, oh, here we go. It's not preferred because general anesthesia affects the baby as well. So what does general anesthesia do to the mom? Puts her to sleep. What are we monitoring on mom?
Respiration.
What are we doing to mom to keep her respirating?
Doing her oxygen.
We're intubating, okay? Anybody who goes under general anesthesia gets intubated, okay? So now we have a baby who just got general anesthesia. And we've used general anesthesia because we had a bad baby to begin with. And now we've just made him worse. Okay? So that's why we try real hard not to do general anesthesia. Okay? Because it causes severe fetal heart rate depression and respiratory depression in the baby.
So mom goes out and you have like 8 minutes to get the baby out.
Huh? Mm.
So, I mean, you don't want the baby not breathing for
Right.
more than, like,
So-
6 minutes.
So how's baby getting oxygenated in utero? Mom, but what's supplying the oxygen? Is baby breathing the oxygen? So it's coming through the placenta, which comes through mom's oxygenation, which she's intubated and we're oxygenating her. So it's not so much an issue when the baby's in utero, but when we get the baby out, now we have an anesthetized baby that's supposed to breathe on their own. We've got mom intubated to keep her breathing, and now we've got a baby who's anesthetized. Now, so it's not advocated for high-risk babies, but if you have a high-risk baby that's tanking in utero, and you need to do an emergency C-section, and the fastest and best way to get that baby out is to do general anesthesia, that's what we're going to do. And then we're going to have a NICU team there to take care of the baby. Okay. On mom's side, greater blood loss, maternal amnesia, of course, so she doesn't remember the birth of her baby, which can be very emotionally traumatizing for mom. Okay. Vomiting, aspiration. Anybody who has general anesthesia has these complications. Okay. Well, we're not so much worried about other people's uterus, but for a pregnant woman, we are worried about her uterus bleeding. Okay, one more, and I'm gonna do it in 15 minutes. I think it will be pretty quick. I hope. All right. Any questions about pain medicine? Oh, darn it. Okay.
Still use lidocaine when you're doing a episiotomy repair if they have an epidural?
Oh, yeah. Yeah, because sometimes, who asked that? Was that you? Sometimes a lot of times when you do the epidural, I mean, it gets everything from here up, but the bottom of the perineum, it doesn't. Okay, the epidural, so yeah. Sometimes, we can do it and it's fine, but most of the time they do. Okay, so external version, you've heard me say this before. This is where we turn the baby, okay? We like to do it by at around 36 weeks because we have room to do it. We've got a smaller baby, we've got more room in there. Hopefully mom is not contracting at 36 weeks and we can possibly turn the baby. The woman comes into the hospital, she gets put on the monitor, we make sure baby's good, okay, and then we may also give mom pain medicine because this is uncomfortable, it does hurt. And we may also give her a tocolytic, which is a medication that keeps her from contracting. because we just messed with the uterus. We just upset the uterus, and so it might respond by contracting. Okay, so we may give a tocolytic as well. Okay, and then they do the turning, and hopefully it's successful. Baby's head down, and then typically what we do is we say, okay, go home. Come back when you're in labor. Sometimes we do it when they come into labor and we're doing our assessments and we're like, that's not a head. So the physician will come in and say, you know, you're in labor, I can try to turn the baby because I know you don't want a C-section, but you're contracting and you're 38 weeks and it's going to be really difficult. We will give it a try. I will try my best. And they will try to turn the baby. But after about 37, 38 weeks, baby's too big, there's not a lot of room, and she may possibly be contracting, which is another force you have to fight against. Now the internal version is, when we do a twin delivery, we labor in the labor room, and then when she's ready to start pushing, we move her into the OR. Okay? It's a precautionary measure because something might happen to one or both of the babies when she's pushing, or one of the babies, after the first baby is born, the other baby now has all this room and they slide down into the uterus and flip all around and become breech. Okay? And if that happens, we can do an internal version where the physician goes up internally and tries to flip that baby around. Okay? But if that doesn't happen, then we go for a C-section. And I've been in the OR where both babies were born vaginally, and I've been in the OR where the first baby was born vaginally and the second baby was born by C-section. Okay, vaginal or C-section or one or both or the other, the woman is going to tell you, I birthed twice. I had a vaginal delivery and I had a C-section, but I'm going to record it as one birth on her G's and P's. Right? Or, yeah. So that's where it gets confusing. So we've talked to you that P stands for preterm. But in labor, in the real world, they'll say, what's her G's and P's? So how many times was she pregnant? How many times did she deliver her paras? Okay? So we call those G's and P's. That can be confusing when you've learned that P stands for preterm. But in labor, we will say, what's her G's and P's? Meaning, how many times was she pregnant? How many times did she para or birth? Okay? All right. So, all right. An amniotomy. An amniotomy is we break her fluid. We break her bag of waters. We don't break fluid. We break bag of waters. Okay, an amniotomy. We go in, whoever was on the tour saw the little crochet hook that we use to go in and snag the bag and break the waters. That's what an amniotomy is. Okay, we do it to stimulate or induce labor. So if any of you have looked at your labor log, there's something where you record augmentation, or I'm sorry, induction. And there's something where you record augmentation. So induction is we are inducing labor. We are causing labor. And we can do that using Pitocin, or we can do that using an amniotomy, because the theory is if you break water, they go into labor. And that is a theory, because that doesn't always happen. Okay? But if she's already in labor and her bag of waters is intact, and we go in and break her waters, we just augmented her labor, or we just helped her labor. Okay? So anyways, the main reason why we do an amniotomy is just to make the labor go faster. That's why we do them. But the other reason is we need to put internals on. So if you were at the tour, you saw the spiral electrode that we put on the baby's head, and you saw the IUPC, which we measure uterine contractions inside the uterus. Her water has to be broke. So if we need to do those things, we got to break her water. Fetal scalp sampling for pH, we don't do that anymore, but if we wanted to, we could get a scraping of the baby's scalp and send that off to test baby's pH. Okay? But the water has to be broke to do that. But we don't do those. So as we said before, we're assessing the color, the fluid, the odor.
There's 4 of us that have to be across town for a mental health
Oh,
training.
okay.
So, sorry.
All right, go guys. Oh, I'm supposed to be done at 10 till. Damn it. I'm sorry. Cuss word on the recording. All right, the rest will be on the recording. Let me go real fast. Cervical ripening, I talked about this a little bit earlier. This is when we want to induce someone and their cervix is closed, hard, thick, long, not in good shape to be induced. we do what's called cervical ripening. We can use that drug I told you about, the little tablet of Cytotec. We can use a drug called Cervidil, and that's the soap on the rope. It's a prostaglandin in the form of a little net-looking thingy attached to a rope. So Cervidil we can place every 4 hours. In Cytotec, we put that in there. We leave the string hanging out. We leave that in for 12 hours, and then we pull it out and induce their labor. The other thing, which is a really big hit and I love, is we can use what's called cervical ripening balloon. And she does need to be very slightly dilated to do this because we're putting a catheter like a Foley catheter, similar to a Foley catheter. The only difference is it has 2 balloons instead of 1. We put that through the cervix into the uterus. And then there's a balloon on the uterine side. We fill up this balloon with 40 to 60 cc's of fluid, and then we pull it down on the cervix. And then we inflate the other balloon, which is on the other side of the cervix, in the vagina. We fill that with fluid, and then it smashes the cervix. Okay? It's kind of uncomfortable to the woman. However, it's not medication. She doesn't need to be constantly monitored. And that softens the cervix. Okay? So we talked about Cytotec already. We talked about Cervidil already.
I'm 56.
Huh?
I'm so glad I'm 56.
If they have Cytotec and Cervidil, they've had a medication, therefore they get continuous monitoring. Okay? So here's the information about those. Cervical ripening balloon I just told you about, similar to a Foley catheter. So the other thing, stripping of membrane. So they can do this in the doctor's office and send her home. But they actually do a vag exam, and they try to grab a piece of the membranes, and they rub them together. Now, do you guys remember last semester membranes are there's 2 membranes, and they're kind of stuckish together. So when he goes like that, he's actually kind of breaking that little adhesive that's in there, causes a bunch of inflammation, causes this woman to go into labor, technically. Okay? All right, Pitocin infusion. So this is our induction agent or our augmentation agent or our after delivery uterine contraction blood minimizing agent. Pitocin we use, it's a black box drug, so very risky med here. We infuse this beginning at a 2 cc an hour dose, very small amount. And then we increase it 2 cc's every 30 minutes, and until we get them in a good labor pattern. After delivery, when we're trying to cramp her uterus and decrease her blood, we're running it at 999 cc's an hour.
Oh, my gosh.
Sometimes we'll run it at 250 an hour, sometimes at 500 an hour, but we can run it as fast as 999 cc's an hour. Okay? They're on continuous monitoring because the thing that I'm doing with Pitocin is I'm causing her to contract. Okay? I need to make sure I'm not causing her to contract too often or for too long of a period of time. If I do that, I could rupture her uterus. Okay? And also, if I'm causing that many contractions, then I'm causing that many times of decreased oxygenation to my baby. So then I could be causing a problem with my baby. Okay? If I cause a problem with my baby, I have to stop the Pitocin. I have to do my intrauterine resuscitations, fluid, position change, oxygenation, turn off the pit to get my baby to be better. If my baby bees better, I can restart the pit. Okay? There's a big protocol, so when you're in labor working, we'll look at the protocol. So it tells us what to do. All right, episiotomy, 2 different kinds, same. One's midline, straight down, one's kind of medial lateral, kind of sideways in the perineum. They just do that so the woman doesn't tear and they can fit the baby out. But they're doing them less frequently, okay, which is great. Basically, basically the physicians are getting a little bit of patience and letting that perineum stretch. And
Is it like a physician preference as to which?
Yeah.
Okay.
yeah. Okay. So here's a look at both of those. Medial lateral, B, straight down. A. Medial lateral is A. Midline is B, straight down. Yes.
On the screen it looks like such a tiny little line, but when I saw the real thing it looked gigantic. I mean, I
Yeah.
was afraid it was going to like perforate her anus or something.
Right. Right.
Yeah. And they did it to my sister at my home.
Yeah.
Okay, so we've talked about assessing every 15 minutes, applying an ice pack. Forceps. I'm going to run through indications. So forceps are going out of favor because physicians are not being trained. Okay, they're just as dangerous as a vacuum as far as for baby, but they're harder to use. You need better skills to use forceps. Okay, so when you place forceps, you're placing one forceps coming down the side of baby's face, and then you're placing the other forceps coming down this side of the face, and then you're hooking those puppies together. Okay, and then when you squeeze those handles, you're squeezing the tension on the baby. Okay, and then forceps is supposed to just be a gentle guiding the baby out. Okay, there was a landmark national sentinel event where the woman asked for a C-section before labor because she was 4'12" and she had this the belly the size of a barrel. Okay, she said, "I want a C-section." He said, "No, I don't do that." And so this lady labored, and she started pushing. The baby got stuck, and he put forceps in, and he put his feet up on the bed, and he pulled that baby out, busted her pelvis, and severed baby's spine. Okay, so you are the nurse, and if you have a physician that does that, you make them stop. You make them stop. Okay, and with a vacuum, it's supposed to be a gentle guiding, just a little bit of pressure, pulling, but just a gentle guiding. Okay, here's the forceps. Okay, here's all your risk factors. We could cause a brain bleed. We can rip the mom from stem to stern, and I haven't seen one forceps place where the mom didn't get ripped from stem to stern. Okay, vacuum assisting, so we're just putting a little cup on baby's head. We're creating some suction, and another gentle pressure as she pushes. Okay, so that's what it looks like. As the nurse or as a physician, you do this and you start giving a little gentle pressure, and you give a little more than gentle pressure, and you pop that suction off. You get 2 pop-offs, and then I'm taking it out of your hand. You can't use that anymore. Okay, they get 2 pop-offs. Period. Okay.
As the nurse, you take it away.
I take it away from the physician. I say, "You've had 2 pop-offs, you're done." And if they try to put that back on, I will reach down and grab it.
How does that go?
Huh?
How does that go?
Yeah.
It doesn't go well if I have to reach down and grab it.
Yeah.
For you or for the doctor?
I'm thinking for the doctor.
It doesn't go well for me because I get my butt chewed. But that is what I do. Because she gets 2 pop-offs. That's a national standard, a patient safety standard. She gets 2 pop-offs. If I let her have a 3rd pop-off and we created an intraventricular brain bleed, then here's my license, because I just allowed that to happen. All right. Indications for a C-section, fetal distress, all those things. If she's got twins, she can do a vaginal delivery, but if she's got any more than twins, she gets a C-section. Umbilical cord prolapse, active herpes. So she can have herpes, but if she doesn't have active lesions, she can do a vaginal exam. I mean a vaginal birth, sorry. Okay? But if she has active lesions, she has to have a C-section. Pelvic size disproportion, placenta previa. So we'll cover placenta previa in the future, but basically that's when the placenta is sitting over top of the cervix. Okay, we can't birth a baby through the placenta. We will cause very bad stuff. Okay, I'm not going to talk about preparation. You guys can read through this. This is basically just prepping. Here is the standard C-section cut, a low transverse. Okay. We don't really do these anymore. This low one, we do this one. Okay, this is called a classic incision, and we only do these in emergency situations. Okay, because she can never have a vaginal birth after that. Never, ever, 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 ever. Okay, she'll explode her incision open. Okay, but if she has that low transverse one, she can try a vaginal delivery. Vaginal birth after C-section. So if she has the low end, she can try a vaginal birth. Okay. All right. I will tell you one horror story, and it happened to my sister's sister-in-law. She came in for labor. She baby, something went south on baby. I can't remember what it was. And we took her to C-section, and we felt we had enough time to do the low transverse C-section because she wanted to have more kids. And she wanted to try another vaginal birth. Something happened during the C-section after we cut it, and we had an emergency situation happen where we needed baby out 2 seconds ago. So then we cut this. So that's called an anchor, and they are cut like this. All right. I'm sorry, guys, I was late.
Does that mean